Hello, welcome back to the Cash PT Lunch Hour podcast. This is your host, Aaron LeBauer, and today my special guest is Joe Tatta from the Integrative Pain Science Institute. And Joe has sent me a message, and I've actually messaged with him before, and I actually have, like whatever, we're Facebook acquaintances, and I've been getting to know Joe and seeing some of the stuff he puts out, and he messaged me recently, and I was like, well, I got to get Joe on the podcast because Joe is an expert in chronic pain, and he is a physical therapist, and he was one of the clinic director of one of the part owner of one of the largest PT clinics in Manhattan, and he's got some invaluable experience and expertise. So, welcome to the show, Joe. Thanks for being here.
No problem, Aaron. It's great to be here and join you.
Yeah, and it's great to finally meet you. I know, like, we've had messages go back and forth, and some of the stuff that you share on Facebook, I just totally love. So, but you don't always show up in my feed. So, I appreciate the information you've been helping people with. So, can you just tell us a little bit about, like, what do you do, and like who you are, and like your 2 minute who you are and what you do and who you help?
Sure. I am a physical therapist. Like you mentioned, I live in New York City, and I help people overcome chronic pain. And I also help practitioners learn biopsychosocial interventions that are missing from PT school or from clinical practice. And I help them implement that into their practice so they can more effectively treat their patients and have better outcomes and a better practice.
Right. That's awesome. How did you first get into PT? Was this something like you knew you always wanted to do, or it just kind of happened upon you at some point?
That's my favorite. It's funny. That's my favorite question. You mentioned that I used to own a larger PT practice in Manhattan. So one of my roles there was the practice grew. I was basically responsible for the hiring and training of PTs. And the first question, it sounds a little like super basic, but like, why did you want to become a physical therapist? How did you get into physical therapy? But it's really a key question for people, because when you're interviewing people and for people who own clinics, you may want to obviously use that question and just think about this. Some people say, well, I read about it like in Time magazine, and it said one is the hot up and coming profession, or I didn't have to sit at a desk and be on my feet. And all those are important questions. But ultimately, when someone gives you a response that's kind of related to their personal values, then you're more likely to know that, okay, this is a candidate or a hire or a coworker or a co-owner that I'd like to be in business with. So kind of longer backstory on me. My mom was a registered nurse. She's actually retired now. She's 72. But when I was younger, about 8 years old, I watched her go through a chronic health crisis, basically. From that crisis, she struggled with not only chronic pain, but she also struggled with anxiety, as well as a little bit of depression. And that went on probably for about 2 years. My mom was pretty smart, though. She didn't really want to engage with like medication or anything like that. So I watched her kind of explore like different things with regard to helping her overcome these problems and these challenges. So she did everything between exercise and nutrition and different stress reduction techniques, and of course, changed her job, which is a big factor. So from that, I was like, okay, I watched someone who was a trained RN kind of get into trouble with regard to her health, and then kind of get out of trouble on her own without, the typical pharmaceutical interventions necessarily. Not that the pharmaceutical interventions are 100% bad, but they don't help a lot of people in some ways. So that kind of was like in my back pocket for a long time. In high school, I was a competitive gymnast, so I had like the exercise, component there. And as I started to think about college, PT was just kind of a natural, because it kind of integrated like that exercise health approach from gymnastics, but also like my mom with regard to being in healthcare, kind of PT was the perfect blend of those. So that's how I kind of stepped into physical therapy first.
Yeah. Did you grow up and have any injuries along the way, or did you just go to, was it just kind of natural because you saw that your mom's ability to help people as a nurse was like, well, I got to get into this healing profession, versus, a lot of people have some kind of injury, whether it's before or during PT school, that PT has made a significant impact as well.
Yeah, I had some aches and pains, like most gymnasts and athletes had, but nothing major. Like I never tore my ACL or my Achilles tendon or had chronic back pain. But I think kind of like most of us now, once you're a licensed health professional, people start to come to you with questions. What can I do for this? Or I've been struggling with this. And I watched them do that with my mom. So I think there is a aspect of wanting to help people, and wanting to help people through whatever chronic condition they had that really drew me to physical therapy.
Yeah. So when you were doing gymnastics, like, were you like super competitive, or is this just like you like tumbling on the floor and jumping into a foam pit, because I think that's a lot of fun too.
Well, I was super competitive in two ways. One, I was a level 10 gymnast, so it's kind
Yeah.
of like right before you get to the Olympics. And then
Okay.
gymnastics for me was always, so it is a competitive sport, meaning you compete with other people. But the thing about gymnastics, which is interesting, and I guess this is true for other sports as well, you have to really compete with yourself. You have to push yourself in that particular sport, both physically as well as mentally. And I think there are a lot of similarities with regard to chronic pain
Yeah.
in that sentence.
Yeah. When you look back on your career as a gymnast, now that you're a PT, through your eyes right now in 2020, do you look back and go, God, I wish I was doing this, or I wish I did that?
I wish I had some of the skills I have now when I was competing, especially some of the more mindfulness skills that we'll talk about a little bit later with regard to ACT. And some of that has shown up in the training of athletes. I just don't think it shows up until college. And the place to really start that, like with everything related to health, is to start things younger. I think people who excel at different types of sports have a really unique skill set of obviously both the physical as well as the psychological and emotional components that all kind of blend nicely.
Right. Yeah. I think it's interesting because, I'm a cyclist. So, I was a category 1, which is right before pro level, though you could be a pro and not make any money in that sport. So it doesn't really matter.
Same in gymnastics.
Right. But I look back, but like the peak age is much older versus really with gymnastics. It's really, you got to be much younger, and maybe that's more training your body. But I look back and go, God, I wish I knew these 2 or 3 things. How much fitter could I be? But really, it's if I knew those and other people knew them, even if they're not in a peak athletic sport, it's how much healthier could their life be when it boils down to, right?
Yeah.
What are some of the key things? I want to get into some chronic pain in a second, because I've treated a lot of chronic pain patients myself. What are some of the key things that, as physical therapists, we should be doing or encouraging, not just with our patients, but with the general public in mind? Especially how do we get some of our knowledge to people at a younger age? Like, do you kind of have an idea like about what your keys are for making that happen?
Yeah, there's a lot of talk about health promotion and wellness in the world of physical therapy. And when I went to school, and I graduated PT school in 1997, there was a little bit of that like in the program, but not the way it is now. With the 3-year DPT, there's a lot more emphasis on health prevention, wellness, health promotion, those types of aspects. Yet, most of us are used to just working with that person one-on-one. And even talking one-on-one, kind of like what we're doing now. Like even my skill set, like even though I've been doing lots of public speaking now for a couple of decades, I think as physical therapists, we do not hone the skill of public speaking. And with that, like that greater health promotion out into the community. And that's really challenging for all of us as physical therapists, even the physical therapists I know that do it really well. And there's a lot of them out there. And I think some of the newer generation with regard to accessing social media, it's a little bit more natural, but there's effective ways to public speak and to get in those types of circumstances with regard to public speaking that we still really haven't broken the glass ceiling on yet with regard to physical therapists. For example, if you go into a bookstore and look at health books, you will see probably the vast majority of them are written by physicians. After that, you get a smattering of like PhDs and maybe nutritionists, and then maybe exercise type people, meaning like the star personal trainer. But there's very, very few books written by physical therapists. And when I had a book proposal, which I wrote in 2013, and I brought it around to like major publishers in New York and said, hey, I think the chronic pain epidemic is about to boom, and I have this book on chronic pain. This is before opioids. It was the typical like, what is a physical therapist? What do you do? Like, oh yeah, like, can you massage is this book about massage? So in my book is a much broader, like integrative approach, but there are so many different levels to reaching the public. It's not just like, just having a good Instagram account isn't going to do it. Just having a good Facebook page probably isn't going to do it. There's a number of different kind of levels and steps you have to kind of ascend to reach that height. And school doesn't prepare you for that. I know some of the work that you're doing with people helps prepare them, but it's just as important to cultivate those skills, and maybe more so than actually your clinical skills, depending where you are in your career.
Right. Yeah. I was just, when you mentioned it, public speaking, I was like, oh yeah. I was like, that was one of the most valuable classes I took in college, was a public speaking class. And it was like this elective thing that we weren't even required to do. And I had to kind of fight to take it. But I've realized like it's all I do right now.
That's right.
And
That's
it's
right.
most valuable, and people just overlook that. So I do think that I mean, there are a couple books out there, but it's really going to take like mainstream somebody to not only be, have a mainstream voice, but multiple, what is it like? They have to have, I think PT, we're going to have someone, who is it? Stefania Bell, who's an ESPN analyst. Like most PTs still don't even know who she is. She didn't have a book. Maybe someone, some people know who Kelly Strett's got a book, but he doesn't have an ESPN slot. You know what I mean? It's going to take someone with like 10 of these slots to really elevate us out of just doing massage on the side.
That's right.
Right?
Yeah.
Well, I hope you get there first.
That's nice. It's a good thought, Aaron. Let's hold on to that one.
You got a podcast and you got a book and you got a course, and you're right down the street from the Today Show. So, if there's anything I can do to help you, just, give me a shout out. But Joe, I want to touch in on this because, I started my career as a massage therapist, right? And so a lot of people came to see me and they would say, Aaron, no one's ever touched me there before. No one's ever touched me or hurt. Like, you're the first person. I'm like, so the orthopedic surgeon didn't touch your knee here? Like, you're basically like VMO. Like, they didn't touch the trigger point there. PT didn't do that. Acupuncturist did. No, and it's not a randomized controlled trial, but it's not just an N of one, because I hear this from other people as well. And then as I started my PT practice, I ended up just having people with like just chronic pain. I was as a massage therapist, and then as a PT, I was still just like this end of the line. I've tried everything. I'm going to come see you. No, we've changed our marketing. So we're not just getting chronic pain patients that are almost unhelpable, but that's where it was. Let's start with, why do you think that's the case? Why are people showing up on my door and other people's doors with, no one's ever done this, no one's ever touched me, you're the first person to touch me where it hurts, and now like I'm getting better, or I'm better, because I'm not magic, and I'm not the only one. Why do you think this is like a case here?
Yeah, I just want to clarify and kind of zoom in on that question. So the question you're asking is, why are people showing up to our clinics almost as a last resort?
Yep.
And then being surprised when they start to find some kind of relief, whether that's symptom relief or whether that's an improvement in their function.
Yes.
Is that right?
Yes, exactly.
I think as PTs, we have to get better at just stating this, and people are more than happy to like copy this down or play this back. And it's a bold statement, and there's a place for this statement, but especially with regard to chronic pain, that so far with regard to chronic pain, we have had a industrialized medical and pharmaceutical complex that has marketed the shit out of, and I'm just going to use that because we're all probably on the same page on this podcast, has marketed the shit out of invasive procedures and pharmaceutical medications.
Right.
And with that, they've destroyed everyone's self-efficacy that goes along with it. And to some extent, there's been a effective brainwashing of people with chronic pain with regard to what their treatment should include as a first line of care. And there's some good research on this as well, that the pharmaceutical companies have gone into major medical institutions and the training of medical students, and on some level have done the same thing. Now, does that mean that there's no place for medication? Absolutely not. We want to be compassionate in our care, and there is definitely a place for pharmaceutical medications. Oftentimes, it's the lowest dose and as a last resort. Is there a place for surgery? Yeah, there's definitely a place for surgery. And as physical therapists, we can actually improve the outcomes of that. But with regard to chronic pain specifically, we really need to start steering people. And this kind of goes back to, not only the work that you and I and everyone's doing here, Aaron, but it goes back to that idea of how do we effectively reach the public and start talking about this. And we have to get better at saying, hey, here are the safe and effective ways to manage acute as well as chronic pain that are out there, and get better at being able to verbalize that and educate that, and then promote it kind of on that wider spectrum that you and I were talking about before.
Yeah, that's awesome. Yeah, I think it's just unfortunate. And I just keep getting to these points where people have had surgery, medication, all these other things, but they've never tried physical therapy, or physical therapy didn't work. Well, what didn't work was something that's very different than what a lot of us might think was actually physical therapy. Um, Going back to treating people with chronic pain, persistent pain, fibromyalgia, there was one thing, and I think you're probably the first person I've talked to, or at least on this podcast, who might know the answer to this. Coming out of school, I gave all my patients the oswestry and the NDI and all these things. And so, okay, well, I got a lot of people with fibromyalgia, so I'll give them the fibromyalgia impact questionnaire. I think I gave it to like 6 or 7 people. Not a single one of them was able to complete it. Every one of them took 20 minutes or more to do part of it. What's up with that questionnaire? And does it actually work? Because it's never worked, giving me anything other than an indication that this person has a lot of indecision in their life.
So indecision is an interesting word. When you look at the research around chronic pain and what happens to, an individual or human organism when chronic pain persists, there's a couple of barriers that are thrown in the way of someone not only helping themselves overcome pain, but also when a patient or a person with pain walks into our practice, and we're trained like in this evidence-based medicine where we're given these battery of tests for things. You have to keep in mind that there are really good systematic reviews and meta-analyses that show when you have chronic pain, your cognitive function is deeply impacted.
Right.
So that means things like completing questionnaires, like one, 5 or 10 question questionnaire might be okay. But now when you have a battery of tests, let's say, that the insurance company wants or we feel are effective, there's an aspect there of their cognitive function that they may not be able to necessarily go through that. So you have to go through it with them, or you have to kind of break it up for them or give them more time to do it. Knowing that anxiety and depression run high in people with chronic pain, mood disorders, just going through those types of questions can be triggering or provoking for them. That's kind of a second one. And then third, it depends on where you live in the country and where you are in the world, but health literacy is another big aspect to it. So reading some of those questions that sound easy and approachable to you and I, who are educated people, are not so easy and approachable for people living with chronic pain who have multiple comorbidities and low health education or low health literacy. So just some things to keep in mind. And as we start to learn more about chronic pain, and we're talking about lots of different ways, integrative ways to treat chronic pain, it makes sense to have a battery of questionnaires, but how you roll those out may be different based on the patient in front of you.
Right. Is there ever a time where, because if no one's familiar with this, this was like a multi-page, like 4 or 5 page questionnaire. Like the Oswestry and Neck Disability Index are like 1 page, 10 questions. Like, this thing was tough. Like, is there ever a time where you would give this kind of questionnaire to a patient?
There's a time. There's a time to, of course, look, insurance reimbursement may want that questionnaire.
Yeah.
So you have to fill it out. This is another thing that I kind of talk to clinicians about specifically. Those questionnaires are obviously reliable and valid and have been studied by very wise academic and researchers. They aren't necessarily always applicable to clinical practice.
Yeah.
So with that, if you're a practitioner, you're a busy practitioner, and you obviously have to serve the person in front of you, there is a place to say, okay, I can deal with like maybe 1 or 2 of these validated questionnaires that take more time. And then I'm going to make my own questionnaire that is based off of research that I'm going to modify for my clinical practice and for my patient population. And I'm all for that. So you can have a mix of evidence-based questionnaires as well as questionnaires that you develop on your own that is specific for how you treat and the information you want to collect.
Right. That's a great answer. Thank you. But Joe, I didn't get into this game to be someone's therapist. Like, I am their physical therapist. I got into this to be a physical therapist, not a mental health counselor. Where's the, and with everything you just said, like I know there are people out there that have that thought and like, oh, I don't want to treat patients with chronic persistent pain, but we are almost sometimes the first person that'll sit and listen to them.
That's
What are
right.
some of the key questions, or maybe even things not to ask, that we can use in one of our, like our assessment, to understand how impactful this person's experience of pain is going to be on their kind of health outcomes?
Mhm.
Do you have a couple key
Yeah,
pieces for us? Yeah.
it's a really good question, and I'll take you kind of one step before that.
Yeah.
And the step before that is when it comes to chronic pain. If you're in healthcare, not just physical therapy,
Mm-hmm.
if you're in healthcare, you're going to come across people with chronic pain on a regular basis.
Yeah.
When you look at the statistics on chronic pain, they're out there no matter what country you're in, and they're in your clinic, and they want your help, and obviously they deserve your help. Even before what questions to ask, I think it's really important that you walk into the treatment session, walk into the evaluation with the concept or with the idea that the person in front of you is completely whole and not broken.
Mm-hmm.
Now, when I say completely whole and not broken, that's very different than what you may have learned in physical therapy school or other types of training, where we're taught to fix or mend or heal people, so to speak. And now we have tools as clinicians that can help people without a doubt.
Right.
And that's why people come to us, and we should use those tools. But kind of interfacing with someone with the idea that they're whole in themselves, and you're just facilitating the behavior change or facilitating some type of change that's happening, whether that's cognitive change or whether that's physical change. You're just facilitating that, and they have the motivation within to help them overcome whatever it is they're facing.
Mm-hmm.
Now, with that, some of the most important questions revolve around values,
Right.
what someone's personally held values are. So, taking the time to clarify cloudy values in someone's life before you set goals for them is the best way to rev up that motivation for behavior change that all of us are looking to strum with regard to clinical practice.
Right. That's great. Thank you. I have like 20 questions in my head,
Yeah,
but
there's a whole lot to unpack in
yeah,
there.
there is. No, I think that, I think a big part of it is that a lot of these patients come in having now been seeing multiple people. Now they identify as, I have a physical ailment or a uncurable physical something. Like, so it's not always their body that's holding them back, but it's their perception. It's the way they see themselves. It's the way they're, it's probably that they've been someone and someone gave them goals of getting some range of motion or doing some activity, and they didn't even care about that activity. They just want to be with their grandkids. There's just like this, we've missed the boat a lot of times. Would you say that that's a bigger case with people with persistent pain, or is that just kind of a case in general if we're just not paying attention?
Yeah, it's a keen observation. So think about it this way. It's natural. So we know from neuroscience and pain psychology, it's natural if you have pain as a human
Mm-hmm.
to avoid that pain, to try to eliminate it, or to try to control it. And to some extent, that's normal.
Right.
What happens, or the struggle, the place where people become stuck with regard to chronic pain, is I attempt to control that pain at all cost all day long. And not only do I control that pain, not only am I only focused on pain control, but I stop doing the pleasurable activities and meaningful activities that kind of bring joy and meaning to
Mm-hmm.
my life. And that's where people really get into trouble. So when we start to look at treatments like we're talking about now, based on acceptance and commitment therapy, which I treat practitioners, is first, how do we start to loosen someone's belief that they have to control first the
Right.
pain before they can return back to activities. So that's kind of where we start with that.
Okay.
And
So,
then as you
yeah.
mentioned, so let me just kind of continue with that.
Mm-hmm.
That persistent attempt to control or fix pain affects how I see myself.
Right.
So at one point, let's say let's say before back pain, I had a rich, full, and active life. I had a job. Let's say I was a school teacher. I had 2 kids. I was a mom. I was a daughter. I was a best friend. I was a community leader. Let's say I led my kids' Girl Scout troop. So there were all these different contexts or environments, if you will, that I was used to circulating and functioning in. Once pain started and once pain became chronic, all that stuff went away. I pushed all that away because all my efforts focused on controlling pain. So the only context, the only environment, the only kind of frame, if you will, that I now see myself in is someone who has pain, or I am someone who has pain, or I am someone with fibromyalgia.
Mm-hmm.
In ACT, it's a certain psychological process we call self as context. Now, if I were to ask you, Aaron, just to fill in this statement for me, I am,
Mm-hmm.
how would you fill that in? I am.
Oh, I'm a father, husband, physical therapist, and a business coach. And I used to race bicycles. Right.
Right.
Yeah.
Right. So right there, you said 4 different contexts,
Right.
right? And one, you said, I used to race bicycles, right?
Right.
So you no longer necessarily identify with a competitive racer,
Mm-hmm.
but do you still identify with someone who is healthy
Right.
or values their health and uses, let's say, exercise as a way to value their health?
Right.
Right. So even if you couldn't continue being a competitive cycler, you can still somehow touch base with that circle of your life through, let's say, I don't know, a weekend competition
Mm-hmm.
or going out and training with your best friend, let's say. And these are things that we have to get better with regard to helping people with chronic pain, seeing that, okay, you may have chronic pain, you may identify with that, but even though you have pain, you can still function in all these different contexts and have a more meaningful life.
Right. Versus everyone's like instinct is almost to shut it all down, or they were told something like you can never do this again. Oh, I can never do that again. I'll just shut it down. I can live without it. But they won't live
That's
a
right.
rich life without it.
That's right. And that's why I started, this conversation with
Mm-hmm.
looking at someone as one, that they're whole,
Right.
and 2, the answers reside in them. So their personal values, each of us have personal values that are unique to us. No 2 people have the same exact personally held values in life. So if we approach someone as pain is bad,
Mm-hmm.
as a physical therapist, I have to alleviate their pain before they can get back to their activities, or even a certain amount of pain relief has to happen before they can return back to activities, then in essence, we're setting up a different context for them, or we're setting up the context of pain is bad, it has to be controlled, eliminated, or gotten rid of, so to speak, before any type of meaningful activity or life engagement can happen again. Now, the one place this shows up with physical therapists often is they ask, well, what's the difference between, let's say, pain neuroscience education or pain
Mm-hmm.
education and, let's say, an ACT approach? Because
Can
pain
you
education,
explain what ACT is? Because you mentioned it.
yeah. So
Yeah.
ACT stands for acceptance and commitment therapy, and
Mm-hmm.
it's a type of psychotherapeutic intervention or cognitive behavioral intervention that grew out of traditional cognitive behavioral therapy,
Mm-hmm.
and it uses some form of mindfulness, behavior change, and acceptance to help people overcome whatever the struggle, whatever problem they're having in life. It's kind of started out in the anxiety realm,
Mm-hmm.
and then we've evolved it with regard to treating chronic pain. So it's a
Okay.
cognitive behavioral techniques,
Right.
cognitive behavioral therapy, but it's what they call a 3rd generation behavior therapy that instead of changing thoughts and beliefs,
Mm-hmm.
focuses on just allowing thoughts and beliefs and helping people re-engage with life.
Right. And through pain neuroscience or pain education, we've adapted and used a lot of things from cognitive behavioral therapy questions and ways to talk about it with our patients, and that's where that bridge is. Right.
That's right. So pain neuroscience education, or explain pain,
Mm-hmm.
evolved out of psychoeducation. So what psychologists used to use and still use what's called psychoeducation. So psychoeducation is one component, one smaller component of traditional cognitive behavioral therapy.
Mm-hmm.
And brilliant people like Adrian Lowe and Lauren Mosley said, okay, let's take this pain education component and let's build this out into this like entire cognitive approach, if you will. And it was brilliant research, and that research needed to be done. There are people who that works wonderfully for,
Mm-hmm.
and there are people who need other things that doesn't work so well. So pain neuroscience education or pain education helps people to change their thoughts or to modify distorted or maladaptive thoughts around pain. And like that should be done with patients, and that may be one component of what you do. And then you may start to weave in other types of interventions like acceptance and commitment therapy,
Mm-hmm.
which focuses on or trains people on allowing thoughts or observing thoughts without letting it impact your behavior. So let's just kind of,
Interesting. Yeah.
yeah, let's just kind of dial into that a little
Yeah.
bit, because PTs are interested in this and they're going to want to know what the difference is. So, for example, pain education, you may educate someone that an MRI scan, an MRI of their back, is not the cause of their pain. That if I
Mm-hmm.
took an MRI of 100 people on the street, there may be 30 that have a herniated disc, yet they have no back pain. So in essence, we're helping them reconcile a biomechanical or biomedical cause of pain to
Right.
more of a biopsychosocial approach. And that may work really well for some people. They may say, oh, that makes sense. Okay, so it's not just the herniated disc, it's other things in my life like lack of movement or
Mm-hmm.
stress that's contributing. For other people, it may be very difficult for them to reconceptualize pain or to adopt that thought process. So in essence, we can help them observe thoughts or notice thoughts. So what we're really saying is that there's a whole slew of research that shows that we're not very good at changing or modifying thoughts. And I want to kind of go through a couple of examples with people so we can go into this. So let's talk about deleting thoughts first,
Mm-hmm.
right? So there's no delete button in the nervous system. So how can we demonstrate that? So I want you to do this, Aaron. So I want you to think about a really happy time in your life.
Mm-hmm.
And just let me know when you have that memory.
Oh yeah, I got it.
Okay. And now as hard as you can with all your might and all of your resources,
Mm-hmm.
I want you to try to delete that memory.
Oh, it's not going to happen.
It's not going to happen.
No.
That makes sense. I mean, who wants to delete a happy thought or happy
Right.
memory, right? How about a painful memory? Do you have a painful memory you can think of?
Yeah, a couple.
Yeah, a couple,
Yeah.
right? We all have them. It's part of being human.
Yeah.
It's part of our experience. So just think of that painful memory.
Mm-hmm.
And same thing with all your might, all of your resources. I want you to try to delete that memory.
That's going to be tough.
Make it go away.
Okay. I cannot think about it for years, but it's still in there.
That's right. And a lot of times, even without us knowing, there may be situations where that memory pops up. So we don't really have a good way to delete memories. The other thing, pain is about problem solving. So you can look at the mind as a problem solving machine, right? So our mind is constantly trying to solve problems. How do I lose weight? How do I become more efficient? How do I get rid of this pain? How do I make money, right? So the mind will problem solve, especially with regard to pain. So fill in this blank. So what I want you to do is to try not to problem solve for me and see if that's possible.
Okay.
So fill in the blank or solve the equation here. 1 + 1 =
2.
Right. So I want you to try to stop your mind from solving the problem.
Yeah.
Or stop your mind from filling.
Just don't even answer.
Right. Just don't. Well, you can answer, but let's try this. Eeny, meeny, miny.
Uh-huh.
What does your mind naturally do?
It finishes the sentence.
Yeah, it finishes the sentence.
Yeah.
Now, if we relate that to pain, a herniated disc at.
Right.
What comes up when I say that?
Oh, a herniated disc at which level?
That's right. So what level, or you might automatically say L4, L5, or L5, S1, because that's what we commonly see on X-rays or MRI scans. So, so basically, the mind is constantly problem solving. When you have chronic pain, even with the best pain neuroscience education or pain education, your mind will naturally try to solve a problem. And then we try to distract people with different techniques. So let's talk about distraction for a minute. So what I'd like you to do, Aaron, is try not to think about a yellow chimpanzee.
Right.
So for the next 30 seconds, I'm going to time you. We'll do 15 seconds. For the next 15 seconds, don't think about a yellow chimpanzee.
All right.
And if you do think about it, just note it and just count how many times you think about it.
I'm going to look at the thing so I don't think about it. So if you're watching this on YouTube, I'm looking down because I'm trying not to think about whatever Joe's told me not to think about.
So I'll give you 10 more seconds.
Yes.
So how'd you do with not thinking about a yellow chimpanzee?
Not very good.
Right. And, we have this with pain too. People say, well, put the pain out of your mind or don't think
Mm-hmm.
about it. Or here are some ways to distract from pain. So traditional cognitive behavioral therapy that many psychologists and some PTs even use, we teach people to distract from pain. And oftentimes that doesn't work. So
Mm-hmm.
let's do this for a second, Aaron. What I want you to do for the next 30 seconds, and you don't have to close your eyes or anything. You can leave your eyes open or you can close your eyes. It's up to you. I want you just to notice the flow of your thinking
Mm-hmm.
and just notice what you're thinking. So everyone at home can do this with us. So eyes open or eyes closed, just notice the flow of thoughts first for about 10 seconds. And now as you're noticing the flow of thoughts, I want you to notice if those thoughts are positive, if those thoughts are negative, or if those thoughts are neutral. And then notice how frequently they change even without you prompting them.
Mm-hmm.
Now, what we have here is a perfectly normal functioning human mind. That's the way all of our minds work. They problem solve, they evaluate, they think all day long, whether you have pain or whether you don't have pain. So pain education has its place, and I encourage people to use that, especially on the initial evaluation. But if you find that that's not working and you're so fused to that idea that I have to change someone's thoughts, you actually don't have to.
Mm-hmm.
There are third wave cognitive behavioral interventions like acceptance and commitment therapy that teach people just observing those thoughts or gaining some distance from those thoughts is just as effective as changing thoughts. So let's do this, Aaron. So there's lots of, so what I'm talking about, it essentially is what's called cognitive diffusion in ACT. And it's a way, instead of changing thoughts, to just allow thoughts or notice thoughts. So you have a Post-it note there, right?
Yeah.
So I want you to just take one negative thought about yourself. We all have them, right?
Mm-hmm.
And just write that one negative thought down. So that one word, and everyone can do this at home. If you have a piece of paper or a Post-it note or an index card, just write that thought down. You have it there?
Oh, yeah.
Yep. And I want you to kind of hold that thought up to your face. I want you to look at it really closely. So you can see it, right?
Oh, yeah.
And I want you just in your own mind, repeat that negative thought nice and slowly. You don't have to tell us what it is. Just repeat it in your mind nice and slowly. And just feel what that's like. So feel what happens in your body. Feel what happens in your mind. Just notice what emotions are attached to that. And then what I want you to do is I want you to kind of take that thought on that Post-it note, and I want you to stretch your arm out. I want you to look at it from far away. Yep, so hold your arm straight out about shoulder height.
Right.
There you go. And now do the same thing. Look at that thought. And just notice if it's different now, that it's a little bit further away.
Yeah.
Now I want you to turn it upside down. And if you can, if you're near a wall or a desk, put that Post-it note on the desk or the wall. And I want you to step even further away from it. So you can still see it, but now you have some distance from that thought.
Right.
So you're not caught up in it. It's not right in your face at all times. A little bit further, it's upside down now. And does that thought feel like it's any less distressing? Or has it lost a little bit of its punch, so to speak?
Yeah. I don't want to throw it in the trash as much anymore.
You're right. That's right. Now, what I'd like you to do is come back to that thought.
Yeah.
And I want you to kind of fold it up into like a little square. I want you to put it in your back pocket. Let me know when it's in your back pocket.
All right. It's in my back pocket.
Now, I want you to think about someone really important in your life, the most important person in your life. And just let me know when you've kind of connected to that person.
Yep. Got it.
Comes up pretty fast, right? Now, would you be willing to have that thought if the activities you did in your life connected you in a more meaningful way to that person?
Mm-hmm.
Would you be willing to even carry that thought around with you all day long, every day, if it meant you can connect more deeper with that person who's important to you?
Oh, yeah.
Right. Now, I don't know what your thought was, but no matter what the negative thought is, whether it's about a personal evaluation, whether it's about chronic pain, whether it's about your self-evaluation about chronic pain, what we did was called cognitive diffusion. So we took that thought and we changed the form and the function of that thought in essence. So Aaron, that thought may come up again, but now you have a simple way to kind of gain some distance from that thought.
We've changed the meaning and the almost association.
That's right.
Right?
Right. So instead of changing the thought, instead of worrying about how do I get rid of this thought, or how do I make that thought come up less frequently, I've given you a way to change your relationship to that thought. And that's what we have to do more and more as physical therapists when we find that changing thoughts and beliefs about pain are not working in our patients.
Right. That's great. Is this kind of like when the patient they've had persistent pain for a long time, now they finally are doing some activity. The activity is not harmful or dangerous, but their body's not used to it. And it's just telling them like, you're in pain, you're in pain, you're in pain, you're in pain. And we have to re-educate them that that's really your body just saying, hey, you're walking and you're tired now. I've always told people, like, well, it's kind of like the signal is kind of mixed up. It's like your body's not used to it and sees it as a threat, but it's really like, that's just like post-exercise soreness, and you're not used to doing it or experiencing it after 10 minutes of walking. You were used to doing that after experiencing it after an hour of CrossFit, but we have to kind of move it along. Is that kind of?
That's right. So pain essentially is about protection.
Yeah.
Your mind, because it problem solves and evaluates and judges things, is always concerned about pain, whether it's acute pain or chronic pain. So in essence, it's like you have this protector within your mind. And when you start to progress your exercise or improve your range of motion or potentially do an exercise that you hurt yourself doing, that protector starts to really chatter a lot and talk. Sometimes that protector sounds like a little old grandma. Right? It's like, oh, Aaron, just be careful. Don't hurt yourself, Aaron. Sometimes that protector is a little more like a bully. If you do that, you're going to hurt yourself, and I'm going to hurt you if you do that. Sometimes that protector is a little bit more like a physical therapist that says, hey, before you do that, let's make sure this is okay. Let's get it checked out by a doctor. Let's get an x-ray. Let's get a scan. Let's get evaluated. So there's lots of different types of personalities, if you will, that this protector within can adopt and can develop with regard to pain. And each of us has kind of like our own protector within. So you can name that person, you can give that person a name. You can identify if that person or that essence, if you will, is male or female. And then the third way is, what type of voice do they have? Is it that compassionate, consoling type of voice? Or is it more like that bully inside? So there's lots of different ways that's what's called humanizing the mind, to help people realize that, okay, I have this mind. It's going to chatter away. It's going to talk. It's going to evaluate. And how are some ways that I can relate to it differently?
No, that's awesome. Wow, Joe, that's great. So before we finish up, I wanted to just ask, is there anything that I forgot to ask you that you think would be valuable?
None that I have, but if you have more questions, I'm good.
Okay. Do you have some resources for people about ACT and the acceptance and commitment therapy? Or I think you also have like a program coming up. Is there a place where they can find that information?
Yeah, I mean, I have some free resources. So if you go to the integratedpainscienceinstitute.com and scroll over to the courses tab and scroll down, there's some things that say free training.
Okay.
You can find an ACT guidebook. So it talks about how physiotherapists can implement ACT. There's also a free 1-hour webinar you can watch there. And I do have a longer 7-week training with coaching calls and mentorship after it. It's called ACT for Chronic Pain. That's a course. You can find that course by going to the URL, which is integratedpainscienceinstitute.com/ACT. So that's /ACT, and you can access that course page there.
Awesome. And for anyone listening, we'll make sure we have that information in the show notes. Joe, do you have a preferred social media platform where you like to connect with people?
Facebook is great. You can just find me at Dr. Joe Tatta on Facebook.
Tatta.
That's right.
All right. There you go. All right, Joe. Well, thank you so much for being here. I want to respect your time. We got to hop off the show, and I could ask you 25 more questions, but we'll have to do that another time. I look forward to meeting you in person sometime, and thank you so much for being here and spending your time with us today. I really appreciate it. This was insightful for me, and I hope for thousands of listeners as well.
Thanks, Aaron. Great being with you.
Absolutely. So this is the Cash PD Lunch Hour podcast with Dr. Aaron LeBauer and Dr. Joe Tatta. I now forgot what I was going to say. So, because Joe helped me delete that memory, but I'll see you guys on the next show. If you got anything out of this, please give us a shout out on social media, Facebook, Instagram stories, and we'll see you next time. Appreciate it.